Welcome back, ladies and gents, to another edition of the Physiotutors Podcast. Today we have with us Mehmet Gem. Mehmet is a specialist hip physiotherapist working in both hospital and clinic in the UK, as well as providing further education on hip pathology. Now, Mehmet has also worked in young elite sport in both football and rugby, and has his own personal experiences that I'm sure we're going to dive into of hip pathology. Now, Mehmet, look, that's a quick sort of 30-second nutshell into who you are. Why don't you take a couple minutes, give us a little introduction to yourself, and then we'll just dive straight on into the wonderful world of hips.
Well, look, thank you very much for having me, Sonny. I always find it awkward introducing myself because I just think I cringe a little bit when I kind of go through my background. But look, if you're listening, thank you for listening. And just so you know who I am, my name is Mehmet Gem. I'm a hip specialist physio based in the UK, originally from London, now in the Southwest. I work for a company called Pure Physio as a first contact practitioner, which is essentially a specialist role within general practice. I have a course that I lecture for, and I kind of teach that nowadays alongside my work, which is a one-day hip course. And my background is essentially originally in sports and exercise science, and then realised that I didn't really see a career in being a sports scientist, and I wanted to be a physio. Became a physio. Then realised I wanted to be a banker and get more money. It was too late, so I had to stick it out and continue being a physio. And then my speciality in hips essentially developed as a result of me developing a hip problem. When I was kind of starting out in physio, I didn't really know what FAI was. This was about 10 years ago. That kind of ignited my interest, ignited my passion. And then everything's really developed from there. I mean, I never sat down, Sonny, when I was 6 years old and told my parents I wanted to be a hip physio. It's just one of those things that's just happened over the last few years. And I specialise in hips in particular for, I'd say, the last 6 or 7. And then that's me in a nutshell, really. I love football, love sport, big Arsenal fan, big sports fan anyway. I've got a beautiful young family. They keep me busy. And, without boring everyone, that's me in a nutshell, pretty much.
Fair enough. Look, props on you for being an Arsenal fan. When I was in the UK, that was definitely my team. Sadly, I have to admit I wouldn't be able to name the starting 11 for the last 6 years. So I've fallen out of fashion.
Never mind. It'll still be in there. You've still got the blood in there, Sonny.
Still got the green of blood. Look, Mehmet, you mentioned there, obviously, your passion for hips sort of developed after your own injury. Now, I think that's as good a place as any to start. So you had FAI, femoral acetabular impingement. Why don't you walk us through that? What's the pathology behind that? And 1, how it occurred for yourself. 2, your approach to it. And 3, now knowing what you know, 6 years of specialism later, how do you think you would have changed what you did or further developed on the things that you did?
Yeah, well, I'll just kind of clarify the pathology first, because I guess sometimes in these situations I take for granted that people know it or have come across it or see it as much. So I don't want to kind of take that for granted. But FAI syndrome is essentially it's a movement-related clinical disorder of the hip. And in order to kind of get the syndrome or diagnose it as a syndrome, we need a few things. So we need the hip to be painful. So you need kind of signs and symptoms. The painful hip, clicking hip, giving way of the hip. And then you need clinical tests. So you need some form of positive clinical testing, commonly a Feder's test. And then in addition to that, we need imaging findings as well. And then if in an ideal situation or in an ideal world, we would have some form of diagnostic injection as well. So we'd need a few things in order to get this syndrome. And it's essentially symptomatic or premature symptomatic contact of the femoral head neck junction and the top of the acetabulum. So it's essentially kind of where you have one bone that prematurely makes contact with another structure in the hip and then causes pain. However, the caveat to that is the morphology of FAI, which is commonly a cam morphology or a pincer morphology, you'll find in people who have absolutely no pain. Those bony morphologies as well aren't actually the thing that's painful. It's the impact of those bony changes on a hip, and in particular the labral surface, the chondral surfaces, the cartilage surfaces, that become symptomatic when sometimes torn or damaged, but equally you can have a labral tear and have no pain. So this is why it's quite a complex condition, because we've got these very unique characteristics of the pathology that we find in normal pain-free hips. So a lot of the time they can kind of get overdiagnosed, and people unfortunately get referred for surgery quite a lot to have this hip shape changed or to have the labrum repaired. And we kind of have, I'd say in recent years, fallen into quite a biomedical way of managing this condition in particular, because it can be seen as a quite simple, well, look, there's some impingement there, let's fix it and then the hip will be fine. But unfortunately, there's a lot that goes into it, Sonny. There's a lot. It's a big surgery. People think hip arthroscopy is just a couple of incisions. We pop in there, fix it, and then everything's hunky dory. Look, this isn't me slating knee consultants. I wish I was a knee surgeon. To be honest, I'd be in a nicer house and have a bigger car. But knee surgery you see commonly. People have knee arthroscopies and they're doing quite well quite quickly. And sometimes people who see hip arthroscopies as keyhole for the hip don't really appreciate the significance of it. In order to have surgery for FAI, in order to get into that hip joint, you need to distract the hip, you need to make an incision to the ligament structures, you lose the negative suction pressure of the hip and the labrum, then that's all repaired, and then you come out of surgery, and then all you see is a couple of incisions, and you think, well, you know what, can't be that big, it's just little kind of keyhole surgery. That was my downfall. This was me 10 years ago, post surgery, a bit naive, not really I hadn't really finished qualifying as a physio, so everything was new to me, really. Didn't really have too much physio input, and unfortunately I did too much too soon, and that's one of the big things that I focus on for patients that I see post-operatively, just trying to kind of make sure that, one, they're supported, and two, they know what to do. Because when you don't know what to do, you shit it all up that I did, and then you end up making your symptoms worse. And I had a real bad outcome. I couldn't walk without a limp for about 18 months. I was really struggling, couldn't play football, didn't run for 2 years. Because pretty much after 4 weeks, I was in the gym, lifting weights, doing upper body stuff, doing too much too soon, went back to work after 3 weeks, and kind of just thought, well, it hurts because I've had surgery, maybe that'll get better at some point. And it didn't. And, I kind of had a real negative experience with it. And that's hence why it kind of instigated my passion for it. But at the same time, it gives me a very personalized insight and empathy for the patients that I deal with now, and equally the ones who might not be doing so well, because I've kind of been on the other end of it. And I know for a fact, the consultant that I saw as a leading, international, worldwide known hip consultant that I went to see at the time based on a recommendation. So I know that I was in safe hands, and a lot of that kind of poor outcome was probably down to my own approach, really, and that's what I try and avoid for my patients now. Absolutely. And it's difficult, because it's not that straightforward, and unfortunately we're in a position now where a lot of people will end up in front of a consultant who was happy to have get the surgery done, and then some patients do well, some patients don't, unfortunately, and that was kind of my experience with it all, and what kind of led me to this point now.
Let's start at one of the things I picked up on at the beginning. So there's a few things that I want to talk about there. There's the array of diagnostics that went into that you mentioned. Then there was the impact of, it's not necessarily the, I hesitate to use the word, but bone on bone. It's not the joint itself necessarily. It's more the condylar, the labral elements of it there. So the soft tissue structures, and then the surgery versus non-surgery. But if we pull ourselves back a bit and go for that diagnostics aspect, you mentioned that in order to completely diagnose it, you need to have diagnostic imaging. Hopefully, you're going to have all the symptoms. You're going to have all these other XYZ shopping list array of things going on. Now, I think if someone's in the US, that's a lot easier because of the private healthcare system. Obviously, there's waiting lists there. I think in the Netherlands, it's also something that, because of the private healthcare element, you can wiggle your way through there and get things done relatively quickly. Now, I know in the UK, it's not that easy to get all of this stuff done, and there's long waiting lists. So is it a practical reality that you wait for all of these diagnostic imaging elements or diagnostic elements in order to make your diagnosis? Or are you happy to go from a physiotherapeutic diagnosis of, look, from everything that I've seen, everything that I've checked, everything visibly in terms of and what I hear in your story, I think this is the way we're going. So after X amount of weeks of treatment, if that's not going well, then we're going to bust on for the rest of the hill and keep that boulder rolling. How do you go about that, first off? And what are the tests that you're using to look for this, or the elements in the story that you're using to develop your image in your head?
Sonny, you're a clever bloke, Sonny. You're a smart man. I can tell you that's a really, really good question. It's a smart question.
I'm going to highlight that and put it in big words.
Honestly, because that's one of when I teach this is one of the first things that I do. This Warwick agreement, let's say that was a game-changing research. Damien Griffin and his colleagues, and I know Damien, he's an absolutely top surgeon. They put together this article that gave us the definition per se, and they kind of broke it down into those 4 elements that I discussed, or the 3 elements, the 3 main kind of criteria. The problem is there's significant limitations to each one of those in isolation. So you say that someone needs a painful hip or clicking hip or pain in the groin, and yes, they can commonly present there, but so can a number of different pathologies. So in isolation, it's limited. We've got clinical tests that, quite frankly, on their own are significantly underwhelming, but also heavily utilized. So we've got a Feder's test, we've got a Faber's test. Both of those have specificity values less than 10%. They have high sensitivity values. So it kind of tells us that if we use them and it's not it's not a positive test, then we can, rule it out fairly. But if it's painful, all it tells us is might be that.
Maybe.
But I can't tell you what it is, because it could be a number of things. And then we've got imaging. And then from the imaging, what are we looking for? Well, we're looking for on AP, on plain radiographs, we're looking for a CAM morphology or pincer morphology that is present in a vast amount of normal, young, active hips. So then all of a sudden we've got 3 things which are, quite frankly, quite easily found in someone who has no pain at all. But unfortunately, those are what we have to utilize all together, to make that picture. But like you said, not everyone can get an X-ray. I'd say the majority of patients that can walk through a clinic in the UK aren't going to be able to pop to the hospital and get an X-ray. So what does that leave us with? That leaves us with subjective signs and symptoms and clinical tests. Well, we know that the clinical tests are pretty crap. So then where does that leave us? Well, it leaves us with the things that physios are absolutely the specialists in, and that's talking to the patient, because that patient is going to give you all of the information that you need. So if you've got someone that walks through your door who's 70 years old with anterior hip or groin pain that has a Feder's test, that's positive, you're not going to sit there and think, well, maybe they have FAI, because your clinical reasoning has used their age as a way of differentiating you to think, well, actually, it's likely to be an arthritic hip. But why is that? Well, an FAI hip tends to present in a younger, active demographic. Remember, it's a movement-related clinical disorder, and movement is that key variable here. So if you've got a young active hip or a young active patient that walks through the door with these kind of signs and symptoms, FAI will have, in the majority of cases, quite a unique, let's say, story. These patients will initially say, oh, I had some groin tightness for the last year, or I used to play football, and after football I had a bit of a groin strain or adductor strain, and I had a bit of a massage and it settled down, and I could play the couple of weeks after, and all of a sudden the picture changes. That irritability increases and the frequency increases, and then their ability to play 90 minutes becomes 45 minutes. And then all of a sudden that's not every week, that's every fortnight or every 3 weeks, to the point where the patient then can't play because it hurts too much. So those patterns of recognition, and what I kind of always refer to them as, are like kind of unique points, unique, almost like a business has a USP. If I said to you meatball marinara, you wouldn't think McDonald's. These little
Subway.
Kind of specific nuances. Yeah, exactly. Other sub sandwich delicatessens are available. But every like pathology has its own slight nuance, and FAI has that but in kind of oodles of it really. And it's our job to try and dissect that and ask the patient, so that by the end of that clinical conversation, we can confidently say, well, look, it might be FAI. I don't think it's going to be X, Y, and Z based on all of the questions that you've asked. So that actually your hypothesis, which you said obviously that you're already starting to treat them anyway, because you kind of don't have access to all the other things, is a lot stronger. So you can't say, oh, it's definitely FAI syndrome because I've not had imaging, but I'm fairly confident because I've been able to rule out some other things based on my clinical conversation and questions and, clinical reasoning. And that's really important. And that's how I work, because not all of my patients will have access to x-rays, but it's our job to try and rule things out as much as possible. And that's the best that we can do, really, if those aren't at our disposal. If that answers, I think that answers your question.
Yeah, I think so. In a roundabout way, it's nailing down those buzzwords, so to say, that will point you in a direction. And it's one of the things that the more and more I talk to a specialist in whatever field, that less and less reliant they are on clinical testing and more reliant you are on what is the person in front of you actually saying. All the clinical testing is going to do is give you a rough direction, but from what they're telling you, that's deciding what road you're going down at the end of the day. So that's the diagnostics side of it. That's sort of what you're looking for when you've got someone in clinic and you're speaking to them when they're there in front of you by the table. Now, what about active testing, functional movements? Is there anything that you're looking for then? FAI, other elements in a squat that you're looking for, of where it's going to be painful, at what depth, or if there's going to be muscle weakness, what are we looking for there?
Yeah, I mean, look, the strength deficits are going to be hit and miss and will vary from person to person. For me, there are a few kind of like physical things that I'd want to understand. Firstly, one thing that's really commonly an oversight is to understanding what hip profile this patient has, first and foremost, whether they've got a normal hip profile, retroverted, anteverted. And you can kind of tell that by trying to gauge an understanding of what their hip rotational axis is. Because if you have someone who has a retroverted hip profile, naturally they'll have less internal rotation. So if you're assessing someone's hip and you're thinking, oh, actually, look, their hip is stiffer because of FAI, well, is it stiffer because of FAI, or is it kind of reduced range of movement there? Because naturally their hip profile is different to someone who is anteverted, who would have more internal rotation and possibly less external rotation. And equally, that will give me an insight as to how that, if that person is squatting, is normal for them. Do they have a narrow stance, or do they have a wide externally rotated stance based on the fact that they're avoiding pain, or is it because that's naturally how they move? And that's really important to start with before we start trying to almost like blame that adaptation for one reason or another. But normally people who have symptomatic hip pain from FAI syndrome will normally have reduced squat depth. And in particular, we know from this, especially from research like Cara Lewis and Joe Kemp and Mike Ryman, common symptoms and findings that we see are things like reduced posterior tilt, or if anything, excessive anterior tilt with those kind of movements. And that's not as a result of that person's anterior tilt being a blame for that in any way. It's just the fact that they don't have, for one, either the motor control to dissociate between those two movement patterns, or equally it might just be down to the fact that they're, again, just used to moving in that way and haven't been able to dissociate when the hip has been painful to change that, really. Internal rotation is something that we commonly will see is reduced with these hips, and normally a downside is a downfall when we're looking at the management side of things as well, because and a pet hate of mine, and we'll probably talk about the management side of things in a little bit as well, but an FAI hip, when it has stiffened up for a reason. If someone has a loss of rotational axis, in particular into internal rotation, that is likely to be due to the morphological change of that hip. So that patient has got a symptomatic hip that is also stiffer from one side compared to the other. It's unlikely that we're going to start getting an increase in range by just stretching it and hammering it to the end range and hoping for the all will in the world that it's going to get looser and better. when actually all you're doing is probably provoking it and irritating it further by pushing to that end range. But yeah, normally those are the things that you'll see: reduced squat depth, likely reduction in internal rotation, and commonly a reduction in hip extension as well, with gait patterns, and also with running, arguably due to pain avoidance, or could be also due to, like I said, the morphology changes of the hip.
Picking up on what you said there towards the end, can we regain that range of motion once the hip has begun to stiffen up? And how do we identify how and why it's stiffened up, and what can we then do for it?
Yeah, I mean, look, it's from my experience, it's unlikely. You know, if someone's being managed conservatively, from my experience and from the patients I see, the ones who aren't doing as well are the ones who are trying to strive to get the hip back to where it was 2 years ago. And if you have a CAM morphology that has altered the behavior and movement pattern of that hip, that's essentially as a result of the change in shape. And that's unlikely to then all of a sudden give that hip more range of movement if we're trying to stretch it passively or actively, whether that's doing hip mobility drills or passive stretching, because the hip has changed how it moves. I think for me, the biggest success is when we start to respect the changes that hip has gone through and to work within those parameters. Because if we start trying to push too much to try and gain what has been lost, it's essentially where, like I said, things fall short and patients tend to find that their hip symptoms get a bit more irritable. But there's so much that you can do. You know, there's ways that you can modify the way a person moves. You can modify the way they exercise. And you mentioned earlier about kind of strength deficits. For me, I want to understand, if I'm going to give someone an exercise to do, why I'm giving them an exercise. And a lot of that comes down to having to test them. You know, we need tangible data. We need to understand if a patient is weak, like, how do we know that they're weak? You can't just resist them with your hand and think, oh, it's a little bit weak. Well, Oxford grading scale of 4 to 3 and all of that kind of shit. Like, you're not going to be able to get anything valuable. For me, even when I'm doing stuff remotely, patients are surprised how much I get them to do on a remote consultation. I'll spend half an hour getting people to do testing on a remote consultation, whether that's single leg sit to stand to fatigue, whether that's a Copenhagen short and long lever, whether that's 3-point planks to identify any issues with anterior hip stability, single leg hamstring bridges to fatigue. You know, all of these things can almost be a way of doing it remotely. And if you've got access to seeing them face to face and you're in a gym, you can then utilize those similar movement patterns or do equivalent and looking at things like 5-rep max testing, or even using a dynamometer. You know, just so we've got some decent understanding as to, look, if they are weaker in a certain area, we know where it is, and then you can clinically reason exercises that you're giving to them. Not just, oh, you've got FAI syndrome, lie yourself on your side, do some clamshell exercises, or stick a band between your ankles and do some side steps, because I saw someone do it once on YouTube and it seemed to be pretty exciting. You know, I think we need to just give patients a little bit more than that, really. But like I said, a lot of this comes down to doing a lot of the right stuff and trying to mitigate pissing the hip off, basically.
So the Jane Fonda exercises won't be a one-size-fits-all solution, unfortunately. I'll have to put my leg warmers away then.
I mean, put them away. I mean, it's good that no one can see you on camera, because obviously you've got them on at the moment with your leotard. But never mind. It's just good for my eyes, Sonny. But yeah, no, like, absolutely. I think we need to we need to give good quality rehab and understand why we're giving it. And we're only going to get that. And it's difficult within one appointment. You know, commonly these patients might need 2 appointments just to assess them, to get them to a point where you can figure out what the best exercises for them are. But like I said, this hip can really quickly, easily be irritated. And unfortunately, what happens is someone will have FAI syndrome, they'll have poor physio, they'll have a negative outcome from physio, they'll go to surgery and have surgery when actually they haven't been managed correctly or enough before they've got to that point. And unfortunately, we know that not everyone has a good outcome from surgery. The majority do, but not a lot do. And you asked before about like the comparison between physio and hip scopes, and there is always going to be, you know, from the research, that especially from like the first one that we got came with the UK fashion trial, it was always like favouring surgical outcomes to physio. But I'm always reluctant with studies that compare things to physio when the physio within the studies is arguably a bit
lackluster.
Yeah, I mean, that's a nicer way to put it, Sonny. You kind of saved my blushes there from what I was about to say. But yeah, let's say lackluster, because when you dive into the studies, one, it's like near on impossible to even find what that physio exercise program includes, because it's like hard to get a hold of. And more often than not, it's just a list of exercises that some physios have put together as like a general consensus of good global exercises, and they'll pick and choose rehab exercises from that. For me, with these patients, half the time I have to make things up. You have to be creative. You have to modify things. You have to alter the way that they move. You have to tailor it to what that person's needs are. And really commonly, they don't even identify those differing hip profiles and how that might impact those exercise movement patterns as well. So, you know, it's a difficult thing, really. It's complex, but yeah, enjoyable once you get on top of it. I feel like I'm talking a lot, Sonny. Sorry, I feel like you've asked me like one question. I'll talk for 10 minutes at a time. Everyone's going to be falling asleep.
Oh, that's perfect for me. It means I have to do less. Now, this is also one of my gripes with a fair few of the studies that I come across, where there's no external or real external validity where you can then repeat it. Or when you look at it, you're like, well, functionally in clinic, this isn't the kinds of things that you're going to do. So it might give a bad rap to what is possible within physiotherapy and what you can achieve. But I'm also heavily biased being a physiotherapist and working multiple days in clinic. So I guess I should and would always look at the studies, like some of the studies like that. But the other element to that, I suppose, is that what is the impact for the rest of the chain? Because the hip is an integral mover for the body. You mentioned also in walking and running, whatever other sport that they're going to do. Do you often see confounding injuries on the same side, or people who have an issue further down the chain, or even going up into the lumbar spine?
Yeah, it can happen. I think more commonly you see people with like contralateral lumbar spine or lower back related issues, whether that's overactivity, compensatory movement strategies that overloads that side. But you do commonly come across that. In addition to that, I think a lot of the time people will think that they have secondary injuries too, but it's actually just like the primary that's presenting in different ways, whether that's kind of more distal symptoms or even kind of like, you know, I said to you at the beginning, a lot of the time it's groin pain. People will think that they have an adductor related groin issue, or even sometimes FAI can present in the buttock or lateral hip, and they kind of get misdiagnosed and mistreated, especially in a female patient quite easily. You know, FAI can mimic hip dysplasia. You know, for example, someone might think that they have FAI and diagnosed with FAI, but it's actually a dysplastic hip. So and then that in itself can have different ways of presenting, and in additionally cause things like an iliopsoas tendinopathy, things like that. So you can get these secondary issues for one, but also, yeah, it can also mimic different pathologies as well. So that's why the clinical conversation from the very beginning is so important, so that if someone walks into your room and says, why do you not think it's that? Well, you can kind of say, well, actually, because of X, Y, and Z in these questions that I've asked, I've been able to kind of rule out that it's not dysplasia, or because it's not a female and blah, 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 you know, if that makes sense. You know, you can get that kind of insight from that conversation quite early to rule those bits and bobs out. But yeah, the lumbar spine one is definitely something that you'll come across relatively commonly.
So what are some of the things for a clinician to look out for if they want to be a little bit more certain that it's not another pathology masking or pretending to play the part of FAI? How can you rule out if it is then a bursitis, or if it is a tendinopathy, or if it is a dysplastic hip? What kinds of signs or symptoms can you look out for as a physio?
Well, I mean, look, the hip dysplasia is like highly prevalent in females. Like, it's very rare to get it in a male. It happens, but it's far higher dominance in females, and in particular in Caucasian females. You know, predisposing factors for a dysplastic hip as well would be, you know, firstborn children, or even breech position into uterine positions as well are predisposing factors. And and family history. So these are questions that you would ask early doors. And, you know, I don't know what position I was born in, whether I was breech or whatever. Like, I'm sure my mum was just keen to get my head out of there. But, like, you know, it's just things like that that you would be important to know, you know, and joking aside, those are the questions that you would ask. So then if you have a slightly older active male with none of those factors, then you think, well, actually, it's unlikely subjectively that patient will fall into that category. And equally, when I'm assessing their hip rotational axis, it doesn't look like a laxed hip with excessive ranges of movement. So we're thinking, well, it's unlikely to be a dysplastic hip. Well, then how do I know it's not adductor-related groin pain? Because I've got the same patient cohort in front of me, you know, a young active male with groin pain that could well be FAI or adductor-related groin pain. Well, that's when you start diving in a little bit more into the subjective questions. You know, when do the symptoms come on? Like, is it an acute onset, or have you had that groin tightness for a year or 2 years, and has that got worse? Do you have pain when you're getting out of a car or put your shoes and socks on or rotating the hip, or is it actually very specific, distinct pain in the groin that you can point to with a finger that's painful to touch and equally painful to resist with those adductor testers, as per like the Doha Agreement and Christian Thulberg study? So then all of a sudden you've got subjective and physical testing that you're putting together to be able to rule it out, if that makes sense. Like, a lot of the time patients with FAI syndrome have this C badge or C sign of pain that they kind of point to, like groin, front of the hip, top of the ilium. Whereas adductor related groin pain, normally they can point to it with their finger. So it's a very specific point onto where that adductor insertion is. And then you've got like the criteria of being able to test it by palpating and resisting and stretching it. All those three things are relatively unique to that. Plus the onset is usually in a quite higher performing athlete, and the onset is relatively sudden as well, with some form of like deceleration type movement, whether that's a kicking or sprinting type movement, different to FAI. So, you know, you're picking these bits of the jigsaw and putting them together. And now it just within 2 minutes, we've been able to differentiate between FAI, adductor related, and dysplasia just purely by talking. So a lot of that information you'll gauge from the patient's just profile and by talking to them before you've even had to go and jump into doing the prodding and poking and twisting and all that stuff.
Fair. And then do you ever, you've mentioned it before, you've mentioned it a couple of times there with the stretching. I also want to come back to the rotational axis of the hip, but you've mentioned the stretching. You've also mentioned that you're not going to gain anything back from it, but do you ever utilize mobilizations of the hip at all for people for symptomatic relief?
This is a personal thing for me. You know, sometimes I do, but like it's in a very seldom group because I'm always kind of giving them other stuff to do. For FAI, I never do, just because I know those are the things that irritate it, in particular internal rotation. And also even afterwards, after surgical intervention, you know, you need to look after the capsular repair and labral repair, and a lot of that can be put under quite a lot of stress at end range external rotation, in particular past 35 degrees. And I've had this argument with people online because a lot of those studies are based on cadaveric studies, but I also respect the leading surgeons that have done those studies and their advice, and I think would be daft not to listen to those people who are doing those operations day in and day out. So I tend to limit that. You know, we've got a hip that may well present with some degrees of micro instability as a result of the morphological changes. So I don't really see the value in trying to almost make it less stable by stretching it more. If anything, we need to kind of like make it more stable by the kind of conditioning and exercises that we prescribe to these patients. So I tend to not give it out too much. I might give some stretches out, obviously, to post-op hip replacement patients. But otherwise, yeah, I just never really, and this is my own personal preference. I don't, you know, people that message me and say, oh, you know, I do banded hip distractions or banded hip mobility or whatever, and it helps my hip. And I'm like, look, absolutely. Like, even if I had a patient came on to see me who said it really helps when I do it, I'm not going to stop them from doing it because it helps. Like, I'm not that egotistical and stubborn to stop someone from doing something that helps them. Absolutely. But if they're not doing it, I don't give it to them as a personal preference, just by knowing, I guess, things that help. And I just find that there's always better way to spend their time doing some of their rehab. And I try, I don't know, kind of everyone's a bit different. I try and limit the exercises that I give patients, whether that's only 3 or 4 things at a time. If I start, you know, swapping what I would normally give for mobility party, I just don't tend to do that. But I think that's my own kind of bias.
Okay. And then how is it that you're going to assess the hip movement axis then?
Very simply, I mean, you could just get someone at 90 degrees and supine, and it would be as simple as just passively rotating the hip in that kind of 90 degrees position. It doesn't have to be much more complex than that. Normally with FAI syndrome, like I said, you'll find the reduction in internal rotation both in that degree and also with the hip in neutral as well. So that's like common finding that you'll find, and that was published in one of the recent papers this year, actually, from an excellent researcher called Lasse. I never know if I'm saying this right, but Lasse Ishoy, which is a Danish researcher. So for anyone who doesn't follow him, I would definitely go and look at his work. But yeah, those are kind of how I would passively look at that, just to give us a little bit of an insight as to just how that hip feels and comparing it from one side to the other.
And then if we're going to move forward a little bit now, going towards the surgery side of things. Now, in the Netherlands, we're really fortunate in that due to the private healthcare system, we can do a little bit of prehab before we go in for the surgery, and that's covered by the insurance. And then when you come out, hopefully you've got that BIBO better in, better out. But what's going to be your approach with someone if they've come out post-op? As like you said, it's not like getting a knee scope. There's a lot more to it. There's a lot more going on in the hip, generally speaking. How are you approaching that with your patients when they come back?
What, as in like from when they're coming back from surgery?
Yeah.
Yeah, I mean, to be honest, I think there's a lot that gets missed from patients. Like, I'm just hesitant because a lot of patients will get referred for surgery in different ways. Some have had the opportunity to come and see a physio and have that prehab, and within that prehab, it's not just exercise, though, is it? There's a lot of kind of time that we'll spend setting up the patient for surgery, their expectations, their recovery timeframes, all those kind of things. And I think that's really, really valuable. And if anything, almost more valuable than the exercises that they're given. And then we've got the ones who have gone to their GP, referred for an X-ray, and then gone to surgery as a result of that. And those are the ones that really kind of fall by the wayside, really, because they don't really have that input. And they probably similar to what I did, end up doing too much too soon, not really being aware of the implications of that, and also what the recovery timeframes are. It's a long old recovery. This isn't going to be like a 6-week job. I try and set the precedent for patients that realistically, if you're just a normal person working and managing this post-operatively, outcomes can take even up to a year sometimes. This isn't going to be like a quick thing. So for me, like, having those expectations set from as early on as possible is absolutely paramount. And I'm always a big believer, prehab's going to be paramount if you can get them in to do the exercise side of things. But, what's prehab involving? That's going to be 4, 5, 6 sessions of one-to-one physio that you'll spend talking to that patient. And it might not be until like the third session where they're like, actually, like, how long is it going to take? Or, they'll end up asking questions that they might have forgotten about. And if you don't have that, it's hard to have someone to guide and support you. For that patient in particular, being aware of the timeframes helps them mentally as well. It can be an arduous recovery process. And if they are struggling with pain, or if they've had pain for so long before, or they've had to delay their surgery, it can have an impact on their quality of life. And if they are at least aware of what to expect post-operatively, and they're seeing us and it's taking a bit of time and it's a bit slow, well, they kind of know that from before what to expect, and it will kind of help that process a little bit.
Okay. You mentioned they're doing too much, too fast, too soon, and the detriment that it can pose to someone's recovery and your own recovery as well. Are there any particular precautions or protocols that you run by yourself, or how are you then scaling up their therapy over the course of X amount of weeks or months? What is your criteria for progression, shall we say?
Yeah, I think the first 4 or 5 weeks is really important, because less is more. I think people are really keen to jump to the rehab, jump to the strength and conditioning stuff, do all the sexy stuff as much as possible. And sometimes the hip doesn't want that. In the first 4 weeks, we need to kind of keep it relatively quiet and relatively calm, not to irritate it too much. definitely not to push it to any end ranges, just some simple active range stuff, and also to limit things like iliopsoas tendinopathies or hip effusion, making sure that we're looking after that capsular repair, all those things that I mentioned to you before, so that by the time we get to weeks 4 or 5, the rehab essentially is looking like a proprioception dominant rehab program that's looking at trying to address the stability, global stability around the hip, not just kind of balancing on a BOSU board, but like understanding how we can improve the stability throughout, so that we know by the time it gets to week 4 or 5 and the hip is still relatively calm and quiet and not irritable, we've built up that kind of deeper stability within the hip, so that if we then move on to other exercises, that obviously the stuff that we would do day to day, the control within the hip joint is far better than it would be if you, let's say, for example, jump to doing squats and lunges at week 2, when we know that actually all those things that I've discussed before about how the proprioception is impaired through the labral repair, obviously the position of surgery and the capsular repair, all those things are impaired. So we're kind of trying to get that back before we can jump to doing the more kind of demanding exercises. But normally, like I said, if you can get the hip relatively calm by week 4 or 5, as things progress further down the line, it tends to be able to tolerate more. Whereas if you've got someone who's post-op and in a lot of pain by week 2, 3, 4, you're kind of firefighting. You aren't able to progress, because all you're trying to do is trying to mitigate that from worsening. And an iliopsoas tendinopathy is one of those things that actually, when you get it, if you do too much long lever hip flexion work too soon, it can really piss it off. And to be honest, it can also almost feel worse than it did, or even similar to it did pre-surgery. And again, that can have a detrimental impact on someone's mental health if they're thinking, well, look, maybe this was the wrong option. Oh, like, what am I going to do? I can't play football. I can't play sport because I've made the wrong choice. And some of those decisions to have surgery sometimes take them months because they're not sure if they should be having it. So, less is more. And a lot of the time when I speak to patients, they're surprised that I don't give them more in those early weeks, but they're happy by the time we get to the next stage, which is, like I said, all around stability and proprioception, that they can tolerate it and it's not irritating it.
Okay, grand. Now, we've spent probably about a half hour just around FAI. What are the other most common pathologies that you come across when you're working in clinic?
Yeah, I mean, the ones that I commonly see, so obviously arthritis is the biggest cause of adult hip pain. So we see a lot of that stuff. And I've just kind of moved from an orthopedic hospital where it was heavily biased towards, seeing arthritic hips of all ages. It's not only an old person thing. I think people always think that arthritis is in an old granny or an old bloke, 72-year-old geezer with like hip pain. But quite frankly, you'll get more and more and more. I'm seeing arthritic presentations in younger adults, in particular, even in athletes. If you have, we know FAI is a risk factor of OA, and sometimes people don't even have their FAI addressed, and sometimes it can manifest and develop into OA. And there are other factors in particular, but if you've got someone who is highly active and for one reason or another has developed an arthritic hip, that doesn't always become evident in later in life. We're seeing it a lot more in a younger demographic. So I'm seeing a lot of that in an athletic population. It tends to be adductor related or inguinal related groin pain. And I'd say probably up there in the top 3 would be lateral hip pain or greater trochanteric pain syndrome. So there's quite a few there. And I think one of the ones that gets missed often, that I guess unless you see hips often, is hip dysplasia. And unfortunately, those are the ones that tend to get missed quite a lot because people aren't aware of it and don't see it as much. And like I said, can mimic other pathologies. Unfortunately, those patients then struggle for quite a long period of time. So there you go. I've listed off pretty much every hip pathology known to man, Sonny, there in answer to your question. But those are probably the top few.
Fair enough. This might be a bit of a dangerous or controversial question. Now, you mentioned you're seeing more and more hip OA in the younger population and the sporting population. Do you think that there is an element of the fact that there are people who are getting fitter, that are doing sports for longer? There is an element of that is factoring into the early onset of hip OA. As, like you say, it used to be something for the old granny. the old biddy struggling to sit down and stand up.
It must be, we are seeing more of it. And I think what's interesting for me is that I'm starting to see higher level athletes with OA, and it's I guess peculiar because you wouldn't necessarily always associate it with those kind of patients, but I'm sure it has to be a risk factor. But I think to some extent it also then depends on what that hip has essentially gone through before. If you have someone without FAI, for example, or no, let's say, pathological changes to the hip, I doubt they're going to then develop OA through just like sport and activity, because I don't want that to be the case, because otherwise then people will think, I'm not even going to do sport for the risk of getting OA, and that's not the case at all, because people have an arthritic hip and still play sport and manage absolutely fine. But there's those kind of risk factors for sure that definitely come into play. Unfortunately, especially with a high performing athlete, time or career time is relatively short. So the years that they're performing at that level are sacred. And especially if you then have patients who are, let's say, playing physical sports, let's say rugby, for example, especially rugby players will tend to kind of brush things off. I mean, I've seen a couple recently with arthritic hips. They're playing quite high level and just kind of managing through either kind of pain relief or just kind of playing through it, with the awareness that actually, their contracts are relatively limited. So that doesn't help, because obviously that puts the hip under more stress. It's unlikely for them, that to get any better, because they're obviously pushing it to their limits pretty much. A good example is, in the public domain, which everyone's quite aware of, is Andy Murray. And actually, fair play to him, it's done exceptionally well to even get back to where he is now, and is a prime example of what you can do even with a hip replacement or a resurfacing. So, I guess there's definitely going to be some risk factors. I think what's important is trying to understand like what sport it is. There's obviously some that are going to put it at a bit more risk than other sports, but a lot of the time they can kind of manage with it. And if you are managing those patients with an arthritic hip who are wanting to play sport at a higher level, don't feel that you need to just kind of bin them off for surgery and say, they need hip replacements. I mean, that's one thing I absolutely hate. It's when patients with hip OA go and see a doctor, and the doctor's like, you've got arthritis and you're going to need a hip replacement, or don't do this or do this, and all of a sudden it kind of just like makes the patient feel crap, whether that's someone who's just doing it recreationally or even at a high level. I think we need to just manage these patients much like with anything else, and sometimes they don't get that, they don't get treated fairly. The kind of people see OA and it's like, okay, well, job done, game over, no point, that's just you need a hip replacement, there's no alternatives. And there are alternatives. Again, it just comes down to just trying to identify, look, what can they do? Let's empower the patient to manage their condition properly. Let's do what we're good at as physios and as physical therapists and whatnot. Let's give them the tools that they can manage by telling them things that might irritate it, things that will help it better, modify where you can, and then allow them to manage it going forwards without the concern that they're actually going to not be able to do anything, if that makes sense. Absolutely,
it does. I mean, it's really good to hear you say that as well, that element of don't just fob them off for surgery. I've spoken to 2 surgeons recently, and it really made me hopeful in that they also had the same approach where, they know people or have colleagues that as soon as they see it, they're like, right, this is mine, under the scalpel we go. And these guys have more of the approach of, listen, let's figure out what you can do. Let's see if we can do this conservatively. And they both take the approach of, it's not my job to get you under the knife. My job is to give you your options and see what's right for you as an individual. And encouraging that element of physiotherapy first to see if there's a way to avoid you going under the knife. Now, obviously, there's caveats to that. If someone's had a traumatic incident or something, or if someone's far gone beyond that point of, hey, conservative care is useful for you, of course, jump under the knife by all means. But with every patient going that way, we don't truly have an element of a semi-control group against the operation to see what the possibilities are. If everyone goes down one path and one path only, or that other one that's less trodden, that's gone a bit overgrown, is always going to look scarier because no one's maintaining it over there. I guess you're probably thinking to yourself, well, Sonny, that's a great little speech you gave there, but where's the question?
That was nice, though. I did like that. I mean, have you thought about writing a book?
It has occurred. I hear I'm a poet of a generation. It's true. It's true. But with that said, then obviously neither one of us want to paint a picture of sport is bad and don't do sport's bad for your hip or whatever. Do you see a particular variety of sports that tend to have more issues than others? Be that runners, or be that a basketball player with lots of rotation, or a tennis player who's constantly having that high impact when they've got to change directions quickly, or a footballer. The rugby player for me makes more sense than a footballer if we just think of this without me looking at the research into this of, the rugby player's got a lot more impact. The rugby player's got a lot more traumatic moments within the game, so to speak, and a lot more chance of something happening. He's constantly being thrown to the ground. He's constantly having to lift these big, burly 100-kilo plus fellas up into the air and getting hit while he's doing it and all the rest of it. So rugby versus football makes a bit more sense to me. But are there other sports, or what are the particular sports that you might see more of this?
OA, do you mean, or just hips, or what?
OA with this early onset OA in the sporting athlete.
It's normally going to be like impact related. I guess like it's different to FAI because that tends to be a little bit more kind of like cutting type sports. So things like hockey and football, soccer, those are the ones that you would commonly see it. But with the earlier onset OA, it tends to be kind of the ones with impact. Because even if you look at the demographic of patients who get this at a younger age, who don't necessarily play sport at a high level, well, what we know is the occupational factors are risk factors, and it tends to actually be farmers. And especially when you look at kind of the incidence rate of hip OA in the younger hip, farmers are one of those kind of risk factors or occupational risk factors that we see quite a lot of, and that's because it involves a lot of like heavy labor, a lot of climbing, tractors in and out, picking heavy things up, being on your feet all day, heavy boots, tough terrain. And it's that and repeated kind of that obviously repeated over a number of years that can essentially then lead to that kind of presentation. But sports related, I would probably say it'd be more impact, more the impact related sports rather than anything else.
Yeah, it makes sense.
But again, you don't want to I think the like you said earlier, you alluded to it. We're talking about a minority here. We're not talking about like everyone who is a farmer gets hip OA, or everyone who plays football gets FAI or whatever. That's far from it. And I guess anyone listening to this, I think the emphasis that I always want to try to make is that the majority of time, everyone, even with these kind of issues, can still tolerate a lot of this and can still manage a lot of these things themselves without any problems. It's not our job to go and tell patients, don't do this because it's a risk factor of X, Y, and Z, or don't go and do this because it's potentially going to irritate it. That's absolutely not the case. I think 9 times out of 10, if anyone comes in to see me who plays football, rugby, goes running or whatever, like I always try and get them to maintain what they're doing, unless that's going to have a detrimental impact into what it is that I'm getting them to do. But more often than not, that's not the case, and that's not what we want to do. We don't want to start telling them not to do stuff, because otherwise, that it's just not what we're in the job for. Really, is that we're there to try and empower them to be able to do things themselves, not to tell them not to, or essentially to stop playing sport. Absolutely not. If anyone's listening to this,
no, I think that's also really, it's important to echo your sentiments there of, look, sport is good. If it does happen, it's in a minority of people. And when it does happen in said minority, there's multiple ways we can keep you going. That it's happening in and of itself isn't necessarily a bad thing. It's just making sure that if something does happen, you pick it up early enough so that you can then course correct yourself early enough and maintain your level of activity. Because at the end of the day, we know from every study that's done, those who are more active at a younger age tend to live longer, healthier lives. They have better bone density, they have better muscle mass. They also have a better outcome if later in life they need to rebuild that muscle mass post-op or what have you. It's always quicker on the uptake. Hashtag muscle memory is a thing. But let's now step away from the hip OA and go to something that's probably a nice one to touch on. ITBS, iliotibial band syndrome. Now, obviously, that's going over a couple different areas. There's the hip, there's the knee. How often are you seeing that in clinic? And then what is the population you're seeing that with? And what's your approach to it?
Yeah, I mean, to be honest, I don't see it as often anymore, because it's quite a, the clinic prior to where I am now, it tended to be a lot of runners. So I used to see quite a lot of them, but I wouldn't say I see a lot of it at the moment, purely because my caseload at the moment privately is only hips as well. So my caseload isn't as varied as it used to be. But predominantly, that would be in those runners, and those kind of crazy runners who live and die by running, kind of like associate themselves as runners. But so much of that, again, comes down to, especially when we're managing these patients, trying to understand where that catalyst is coming from, where that biomechanical driver is coming from. Is it a proximal issue in the hip? Is it a biomechanical issue distally? Is it something from the foot and ankle that might be driving these biomechanical changes? It's trying to understand what is the catalyst for that. And unfortunately, more often than not, the narrative for iliotibial band syndrome is still the same. It's still this. It's a friction issue. It's a tightness of your IT band. Let's foam roll it. Let's massage it. Let's stretch it. And it's frustrating that we're still having to have this conversation with not you and I. I don't mean that you're frustrating me, Sonny. I just mean this narrative is frustrating.
It's been a long time. Yeah.
It's just narrative is frustrating that people, if you Google, ITB syndrome on YouTube or whatever, you still come across the same incorrect management tools of this kind of issue. However much good information is out there, you still kind of have that poor info. So for these patients, it's just a case of trying to understand, if it is, like I said, if it is a proximal issue in the hip, let's try and identify, is it because there's a weakness in and around the hip, and what we can do to address that. But equally, you mentioned before anyway about that synergistic chain from top to bottom, and this is a key example of that. It's kind of like middle of the chain, seldom the driver, but always the effect, really. And it can be a problematic thing, especially for runners, because running's a thing that they love doing. And unfortunately, the people that tend to get this are the runners who run and run only. But the saying that I have is eating apples is good for you, but you wouldn't only eat apples all day every day, because obviously make you sick. You can have too much of a good thing. And sometimes this is similar with these as well. And runners always need to have some degree of strength and conditioning work. And I think you guys have got, I think Benoit's got something with you guys with a running course, and he's the perfect person to talk to about running related injuries and the implication it can have on someone's capacity to do what they like to do, really. So there you go. Without any requests, I've put in a little plug for one of your courses there for Physiotutors.
There we go. Fantastic. Your $5 in the mail, mate. With that said, then, something you mentioned there was the biomechanical drivers. Now, this is something, actually, there's two things that you said there. One, man, I cannot stand it when I see people foam rolling their IT band thinking that's going to help. It really aggs me when I see that. And I hear it was prescribed by their previous physio or something. And I'm like, yeah, that gets to me quite heavily, because like you say, there's a mountain of good information out there that shows that, hey, this isn't going to help you. And my eyes are bulging out my head as I say that. But you mentioned the biomechanical drivers. Now, especially on social media, this is something that is getting a lot of stick, and there's all this biomechanics, they might not be as important or what have you. Now, as someone who specializes in the hip, how often in your caseload would you say that biomechanics are a thing for your patient, that modifying those can be helpful or beneficial for your patients?
Yeah, I mean, look, I think it's the moment we start, I think it's important to understand how someone moves. It's important for a clinician to understand an individual's biomechanics, in the sense that you want to see if they move in a certain way, if their movement is impaired, if they're habitually changing their movement patterns as a result of pain or whatever. I think the slippery slope that a lot of people may fall into is when you start having that conversation with the patient and relaying information to that patient in the sense that, oh, this hurts because this is a little bit off, or this hurts because your biomechanics are demonstrating, whatever, like knee valgus, for example, or something like that. It doesn't sit well with me when we start blaming patients for their problem. And when you start kind of saying, like, this is why it hurts because of this reason. And it's almost like a very simplistic way of trying to figure out like why someone's in pain. Because quite frankly, if it was that easy, our jobs would be redundant. It's not an easy thing to try and diagnose where someone's pain is coming. Pain's so complicated. That's the most annoying thing about all of this stuff. It's just such a complex entity that for us to try and associate everything solely to biomechanics, I think would be too simplistic. And I think that does happen though too much. I think that's quite easy for people to get into the thought process of it being we'll use knee valgus as an example. Your knees caving in will strengthen up your glute med and that should be fine. Realistically, it just doesn't work like that. But unfortunately, that's still, however many of these talks we do, however many people do podcasts, however good accounts there are on there, that is still normally what you come across, unfortunately. For my case, though, as a result of obviously the stuff that I've just spoken to you there, like the biomechanical aspect of things will be what we discussed probably earlier on regarding the FAI patient. But for the majority, I would just want to understand myself. I wouldn't necessarily relay that to the patient too much.
Okay, yeah, and I get what you're saying there with regards to for example, the knee valgus, and it becomes too simplistic a model to approach and put the blame solely focusing on that one aspect. Wholeheartedly with you there. However, I think the other, or it's not so much of a however, I think what's important for people to remember is, one, we know that if we take the runner, they usually need to put in a little bit of S&C into their program, because normally running is the only thing they do. Like you said, an apple all the time, every time isn't necessarily going to be the best thing for them. But then the other thing we need to remember is that valgus knee isn't always necessarily something that we can even fix when they're running. There's been a lot of evidence to show that actually, even if we try to fix their running pattern, their running mechanics for that valgus knee or what have you, or a foot that's dropping in, let's say, that doesn't necessarily take hold in the long term on those long-term follow-ups on that specific patient population. Now, I think with that said, is there an element of, can it add to the complication or add to what's going on? Maybe. Is the reason that it got better more so that you fixed the valgus, or is the reason that it got better because, generally speaking, around the hip joint, that patient is stronger, the muscles are performing better and able to carry the load better? Would you say that's probably more so where that's coming?
Oh yeah, absolutely. I think I'd say majority of the time, if not all of the time, that is exactly what's happening. And also you're kind of like telling the patient and priming the patient for these exercises to help them, and that's obviously going to be one massive help. But it's very unlikely, people's knees fall in all the time, people's knees go over their toes all the time, people move in different ways. That's just part of how that person moves. Much like how I said earlier about like how people have different hip profiles, people have different profiles of the way that they move and different strategies of how they complete exercise and movement patterns. So for me, it comes down to like have those exercises, like you said, most likely condition that person to tolerate the activity that they're doing more so than actually this muscle is putting your knee inwards so it's nice and straight and in line with your knee. I'd say that was, it's unlikely to be a case. But look, there are times where biomechanics does play a far stronger role. For example, ACL, return to running and landing technique and force production, all those things. It does have a role to play in certain aspects, but obviously based on the patients that we're discussing, it's not quite the same.
No, I'd say I would argue post-op, it's more important there, as we know there's neuromuscular changes as how the body uses that muscle around there and how your mind perceives your movement. I think in that it would be very foolish for someone to argue that biomechanics don't play a factor in the rehab. Even in a shoulder operation, you see afterwards that the way someone uses their shoulder, uses their arm, is in a, not always, but in a different way to what would be their normal, let's say. But on your general day-to-day, yeah, it might not necessarily be as important. Now, one of the things I asked you right at the beginning was, what would you have done differently in your own rehab, knowing what you know now, after specializing, after seeing so many different hips and different approaches that you would have taken? What would have changed?
Yeah, like in that instance, I definitely didn't. Well, I did no rehab for it in any way, which is crazy to think. Obviously, being at uni at that time as a physio, but my route was literally like, bizarrely, GP, scan, consultant, and then surgery. So I had no rehab before, and even afterwards, really, I had no outpatient physio, because the hospital that I had the physio, that the surgery in, wasn't close by to where I live. So yeah, realistically, I could have, and again, it comes down to the things that I recommend now: prehab for all those benefits, and also post-operatively. And just echoing what I said earlier, and not to kind of like repeat myself too much, but it just comes down to not doing too much too soon and getting a better understanding as to, or trying to, what I would have done differently is try to get a better understanding as to what my expectations or what's expected of me in regards to a rehab and recovery, and also what not to do to irritate it. So yeah, it would have come down to those points, really.
Okay. And are there any key points that you can give to the listeners in terms of movements, or not necessarily movements, but things to avoid over irritating that hip?
What, post-op or pre-op?
Post-op.
Absolutely, yeah. So the main thing is, don't push to end ranges, don't do any hip mobility work, don't do any long lever hip flexion work in the first few weeks. Don't start running until you kind of have been signed off to do that, and that would be until you've at least been able to get to the, the dynamic stage of the hip, and that's the dynamic stage of hip rehab, which is normally a fair few months in. Those would be the key points. If rather than kind of diluting that too much, those would be the absolutes.
Okay. You mentioned there the don't start running until you get to the dynamic point of the rehab. What is your criteria to start running, out of interest?
Until someone, I would want my patient to be able to do. So the dynamic hip for me is rehab that involves multiplanar, multi-directional, force production, landing technique type of rehab that encompasses all those things, whatever that might be, both bilaterally and unilaterally, to the point where they can conclude that section of the rehab without any issues. They've demonstrated an ability to absorb the force and produce the force around the hip and the pelvis without it bringing on their symptoms, or with them not kind of like I said, irritating the hip with the amount of force that we're putting it through, to then allow them to sorry, I just cut out there, without them being able to get back to running. I guess like the point I'm trying to make is so it doesn't irritate it when they do get back to it. The worst thing would be for them to get back to running too quickly without being able to tolerate what we're getting them to put the hip through, and then essentially them taking a step back within the rehab program. So that would be like the dynamic element of it, really.
Okay, nice. Reason I asked that is I've had a few patients in the past where they've moved from one area to another, so they've had to move physio, and they've been running, and their physio is telling them they can go back to sport, and they're completely unstable on one leg, or they're unable to push even half their body weight on a leg press or something. And I always find that very curious to see what the criteria was that the other person was thinking was acceptable for someone to return back to function, or high level functioning in essence. Do you ever use any hands-on treatment at all with your patients?
I'm not against it.
That's a good start.
I'm not against it, yeah, but it's just like the way that I do things, I tend to not necessarily do it, and I don't know why, Sonny. It's just my preference. It's not a bad thing to do. I know some people do it. I know some people that get good results from it. You know, the good thing about our job is everyone works slightly differently. Everyone's got their own way of working. I've got a way of working that I enjoy and that I find works well for me, and that involves it being significantly exercise based. But yeah, that's not to say that people who do it for these patients, you know, aren't doing anything good at all. No, it's far from it. Yeah, it definitely helps some. But for me, it's just if I'm being honest, I could easily sit here and just like kind of paint a lovely picture. Like I'm the most perfect physio in the world. Oh yeah, I'll do everything, a little bit of this, a little bit of that. But like, quite frankly, I don't really do it at all. So that's just how I work. But yeah, not against it though.
Any adjuncts at all that you use to your treatment, dry needling, Compex or anything like that?
Compex, yeah. I mean, I post-operatively, if patients have access to it, then that would be great. But not really. I used to do acupuncture a long time ago. I don't really do that. You normally just get the patient to kind of complement their rehab with a glass of red wine now and again, and that normally does the trick for their pain levels.
Fair. I like that. That's good advice. I'm going to take that and run with it.
Disclaimer: that is a joke.
I can edit that bit out. It's all right. The joke. But personally, I do use it in clinic. But what I tend to try to do with the hands-on is that if I use it, it's not a big part of the rehab, and it's only in the very early stages. And another part of why I do it is it gives me a good little bit of time to develop some rapport with a patient as well.
Yeah, absolutely.
It's not necessarily always the best. But.
No, but absolutely. And I think rapport is like paramount. I think that's the most important thing. I think that you can have all the knowledge in the world. If you can't build rapport, you're not going to get a good outcome. And yeah, I absolutely use it for other things for sure. But for these patients, it's just I've got into I get a bit of a routine where I don't tend to use it too much. But yeah, absolutely use it for other things for sure. I'm not like Adam Meekins, who I like, by the way. I know Adam. I'm not like him, where he's like completely against it. I do it for some things, but yeah, not really for these.
Yeah. All right. And have you got any particular reading recommendations for people at all? Of you mentioned a researcher earlier. I think it's Danish researcher, was it? Yeah,
there's lots of good research. I think if you look at any of the researchers from Denmark, you'll find them on Twitter. So Lasse Ishoy is one of the main researchers, Christian Thorberg, Mike Ryman, and also there's a University of La Trobe. If you follow them on Instagram, they've got a force group, FORCE, and they come in. Loads of good research comes out of them every year. Those would be. I mean, I could probably list things off for ages, but yeah, feel free. I mean, like if anyone wants to kind of like talk about any cases or wants any articles or advice, then feel free to reach out. I'll happily help guide anyone after listening to this.
And where can they find you?
They can find me either on my website, which is thehipphysio.com, on Twitter, which is @thehipphysio, and on Instagram, which is the.hip.physio. So very original. I've kept it easy. I'm a simple man, son. I told you.
What was it? Ron Seal does what it says on the tin.
There you go. Absolutely.
And if you were to give 3 tips for anyone, whether they're specializing in the hip, whether they're a specialist in the hip, or whether they're a new grad coming out of PT school, what would be the biggest 3 things that you'd say to them for them to ensure that they're doing right by their patients?
So first and foremost, first tip would be get in front of as many different patient groups as possible. Different patients mean different ways of communicating, and I think that's really, really important to get that experience. 2, don't worry about specializing too soon. Don't worry about kind of jumping into one role or a fixed role. Like if you know that's what you want to do, then great, but get as much as experience as possible in different areas if possible. Most importantly, like I said, with patient groups. And 3rd tip as well, don't worry about going on too many courses too soon. I think if you're a new grad, sometimes new grads want to kind of do as many courses as they can do. And I mean, I don't remember half the course I did when I first qualified, but I know that the most important thing that I've gained from my career is my ability to communicate with patients, to be able to really build that strong patient physio alliance and rapport that we discussed earlier. And for me, that's my most valuable tool above and beyond anything else is, above all the knowledge that I have for hips and all that stuff. I think my biggest asset and the thing that I like to utilize the most is my ability to just talk to different patients and build that connection. And I think that really helps. So that's, will be my third point.
Okay. And I think final question from my side is, what is it that you think that you do differently to your colleagues across our cohort of physiotherapists? What do you do differently, do you think?
Oh, I don't. I mean, there's a lot of people far better than me, Sonny. And there's a lot of people that know a lot more than me as well. But I think, look, all I do is try and implement my experiences, my knowledge into helping patients as much as I can do. But I wouldn't say that I do. And that's why my course is called Simplifying the Hip. There's a lot of kind of times that we overcomplicate things. And I think if you understand how to identify pathologies and rule out pathologies, one of the things that I like to do, what I kind of try to do with my patients, is to make sure that my clinical reasoning is as strong as possible. So when I'm treating something, my hypothesis is based on sound clinical reasoning. So then I can say quite strongly that what I think I'm treating is the right thing, rather than just, treating it out of, hit and hope kind of situation, if that makes sense.
Sounds perfect. Look, thank you very much. Really appreciate you being able to come on with us. Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time, peace.